Welcome back to the afternoon session. I'm Walt Tenling from the Uniformed Services University. To kickstart the afternoon, we have a timely session on stress management in the Academic Health Center, strategies for personal health and well-being, personal and system health and well-being. And to lead us in this discussion is Dr. Stephen Wengel, who's the Assistant Vice Chancellor for Campus Wellness at the University of Nebraska Medical Center. Dr. Wengel, over to you.
Thank you so much for that introduction and welcome everybody here. I have been looking forward to this meeting for a long time. I wish we could do it literally in Chicago as originally planned, but obviously we can't. But I look forward to hopefully maybe some subsequent year to doing that and meeting you folks. But thank you for your participation here. Let me just kind of dive right into this. I'm going to share my screen. So hopefully now you can see my screen. Just a quick comment. You could perhaps see on my little thumbnail that I appear to be standing in the middle of a cornfield. I'm actually not. I'm in Omaha, Nebraska, which is on the eastern side of the state of Nebraska. That picture behind me is some cornfields out in the western part of the state, which, I was out there for a tour seeing our nursing college out there, and it was last November. It was very peaceful, so I took that shot, and I thought, I'm going to use that as my Zoom background most of the time. I think peace is a good thing. We all need a little peace. These are stressful times, right? So let me just kind of dive into this and tell you a little bit about me. So there's a picture of me doing telehealth to my patients. I'm a geriatric psychiatrist, so all my patients are 65 and older. And I see people in nursing homes and in their own homes, of course, doing everything virtually by Zoom now because we have that technology and we're trying to keep our patients safe. But I've been doing that for about 29 years here at the University of Nebraska. I've trained here. I've lived in Omaha, Nebraska pretty much all my life. I like to consider myself a recovering department chair. That's my little feeble attempt at humor. So I know something about medical administration. I took a little side tour as the chair of our department for about 14 years. But then about 2 years ago, my dean and my chancellor asked me to move into this new role. They created a new wellness role for me, knowing that I've been passionate about this for a long time. I've been studying the effects of meditation and other things for many, many years. Been using meditation techniques myself to manage my own stress, and I'm going to teach you some techniques here later that you can use personally. But I really care about the system too, our system and your system, because healthcare is a contact sport. Even before the pandemic, it's a stressful line of work, whether you're a clinician or whether you provide, CFO and similar kinds of administrative support. Your jobs are just as stressful as mine, even if you're not a licensed provider as I am. So I'm hoping that this will be something that will be of use to you personally, but also professionally. I'm going to warn you in advance. I'm trying to pack 45 minutes worth of material into about 20. And so I'm going to talk like an auctioneer, and I'm going to breeze through a number of slides, but you're going to get the slides. If you haven't gotten them already, you're going to get them so you can go back and look at them later. So let me just sort of dive in. This is what I want to accomplish. Talk a little bit about stress in healthcare pre-pandemic, but what's our new reality looking like? Talk about some of the stress and wellness implications specifically for academic health centers, but then really talk in nuts and bolts terms about what we can do, what you can do, what I can do for our own personal kind of stress management and well-being, but also collectively for our institutions. And then I'm going to leave time for discussion. I really think that's the best part, is I really want to have a discussion with you at the end so I can answer your questions or get your ideas too. But I'm going to start with asking you to do a little what I call micro practice. So I've become very fond of the concept of doing micro practices. You may not have 20 or 30 minutes a day to do yoga and meditation and all. I hope you do. I do 10 minutes of meditation every day, but let's say you don't. Do you have 12 seconds? I bet you have 12 seconds in your day. Let's practice a 12-second breath. So I'm going to ask you to do this on your own. Normally, I would do this with you, but in the interest of time, I'm just going to tell you how to do it, and I'm going to ask you to do it on your own. Take a nice slow breath in. Count to 6 just inside your head, not out loud, but count to 6. I trust you. You know how to count to 6, obviously. And take a nice slow breath in for 6 seconds. Hold it for 2 seconds. and then count to 6 as you exhale. And I'll tell you, the exhale is the hard part. It's hard to exhale that slowly. But if you do that four breaths in a row, you will turn on your rest and digest part of the nervous system as compared to the fight or flight system. It's called the parasympathetic nervous system. That's the rest and digest system. And slow breathing kind of magically flips the switch and helps you be more relaxed. So you can do this in the middle of Zoom meetings. You can do it when you're driving your car and you're stuck in traffic. You can do it before you're getting ready to give some big high stakes presentation before the board, whatever it is that makes you stressed. You can do, 4 of these breaths, or even if you do 1 of them. So I'm going to let you practice that on your own. I really, really encourage you to do it. I've been doing this myself for the last couple months. And once you get the hang of it, you find yourself just automatically doing this throughout the day. Okay, but I'm going to keep plunging ahead in the interest of time here, and again, try to frame the conversation. So the good old days before COVID-19 kind of shut us all down right back in March. So thinking back, I used to give a lot of talks on burnout and depression and suicide in physicians, nurses, and others in healthcare. And so I would show this slide frequently, talking about the really high rates of depression and suicide. So one of the statistics you'll see over and over again, about 400 physicians kill themselves every year that we know of, probably more, because physicians are pretty good at covering it up because they know how to do it. But that's a lot of physicians. We have the highest suicide rate of any profession. But it's not just us. 1 out of 4 ICU nurses have symptoms of post-traumatic stress and so forth. So this is the kind of talk I used to give. And I used to talk about burnout a lot and the 3 symptoms of burnout. And incidentally, this applies again to anybody, whether you're CFO or MD or nurse or what have you. Emotional exhaustion, just at the end of the day after day, you feel just completely wiped out. We all have days like that, but this refers to frequently feeling just completely wiped out. Depersonalization, that's a long mouthful of a word, but it refers to treating other people as if they are not persons. So you start treating people like, if you're a physician, you start referring to patients not by their name, but by their disease. I got to go do the gallbladder in room 6. That would be a sign of depersonalization. But treating others, less empathically. And then low personal achievement. Boy, I'm busy. I seem like I'm really busy, but I'm not really getting anything meaningful done. Those are the 3 cardinal symptoms of burnout. And if you have even one of those for a protracted period of time, it suggests, doesn't prove, suggests that you might have some burnout. And again, this can apply to anybody in any career. And then again, pre-pandemic, I looked at these statistics, used to present these statistics. Medscape puts out a depression, burnout, and suicide report every year. And again, this is a busy slide with lots of numbers. Don't worry about the numbers. But every year we look at different specialties in medicine, see who's most burned out. So right now, urology, for some reason, is the top of the chart, and neurology right behind them. My field of psychiatry down here at 35% of us, only 1 out of 3 compared to half, but it's still nothing to be really proud of. So the bottom line is physicians in general, lots of burnout going around. And again, I remind you, this is pre-pandemic. And what are the things, what produces that burnout? If you ask physicians, they'll tell you, over half of them will say it's bureaucracy. It's too many things we have to do, clunky electronic health record systems. And again, I suspect you've heard that. If you can't talk to a physician for more than 2 minutes about their work without hearing about the electronic health record and so forth. But interestingly, there's, some generational effects. Gen Xs seem to be affected more, and there's a gender effect. Women appear to be affected more, at least according to this Medscape thing. And then the thing that really it concerns me is when you ask physicians about suicide or suicidal ideation or ideas of suicide, 1 out of 4 or more will tell you, yeah, I've had suicidal thoughts. So it's still really prevalent. And if you ask physicians, okay, what are you doing about it? Are you getting mental health? Most of us, 2/3 will say, no, I have not, and I'm not planning to, because they're afraid we're going to lose our licenses and so forth. That doesn't generally happen incidentally, but physicians are always worried they're going to lose their license if they see a mental health provider. Anyway, that's before the pandemic. And so I used to, and I still do, use this model, figuring, okay, if half of physicians are experiencing burnout symptoms, that's a public health crisis. And when you deal with a public health emergency like, oh, I don't know, a pandemic like we are now, using this public health model is pretty helpful. Prevention, screening, and treatment. And so I spend a fair amount of my time trying to do prevention with groups of healthcare trainees and providers, but also administrators, because again, your jobs are just as stressful as mine. How do we prevent this? So it's about self-care, and I'll talk about some of those techniques later that we can use to try to keep ourselves healthy. But even so, some of us are going to get depressed, some of us are going to get burned out, so we have to screen for it, and we have to make it easy to get screened. And then some folks are going to need formal mental health treatment, hopefully the minority, but some people will. How do we get people into treatment? How do we make it confidential and accessible and so forth? So that's how I spent pre-pandemic a lot of my time kind of thinking about this. How do I work? How do I do things at all three different levels? And I'm going to show you some examples of those later. But here's our new reality. So we have medical students that we took off service back in March, and they're learning from home. I don't know, I mean, insofar as you can. And, students like to volunteer. So a lot of them at our institution, and I'm sure at your institution, they got kind of bored and restless because they felt like they really wanted to be in the trenches helping people. So they put together a lot of really neat volunteer activities, which I thought was very heartwarming. And then some of the faculty did really creative things. Here's a faculty member at Johns Hopkins who taped a cell phone to the inside of his hazmat suit there so that he could virtually have students go to the ICU with him and they could still stay safe in their apartments. So lots of creative approaches to this. But then we have comments like this, from a faculty member in Florida. I'll be honest, I don't know what the future of medicine is going to look like or the future of medical education is going to look like. The pandemic has been a major disruptor. Well, no kidding, right? But it's also creating opportunities to think about new ways of learning and delivering healthcare. So we're getting, this is the crisis of a lifetime. If students can learn from it in appropriate ways, it's going to make our future physician health workforce better. Hopefully true. Don't know what that means. But let's shift gears a little bit and talk about you and me and how we react to stress. Let me just tell you, our brains like the three S's: sameness, safety, and security. And when those things are lacking, fear and anxiety tend to fill in. And in times of uncertainty and rapid change like now, that is just bound to happen. So I would tell you that if you've been feeling distressed, you are probably absolutely normal. Distress, emotional distress is not a psychiatric condition. It is a normal part of being a human being. And I think we are all at risk for emotional distress. My patients are, the people that care for my patients are, the families my patients are, I am, my fellow healthcare workers are, you are. We all are at risk for this. And it's not because you or I are weak or mentally ill or anything like that. It's a function of the unique challenges of our time. These are just uniquely challenging times. And so these are some common things we're seeing in our patients, in our fellow providers, and just human beings in general. A vague sense of unease. Even if your day's going pretty well, you might find you just feel kind of vaguely uncomfortable. You might be less patient with family members, significant others, coworkers. You might have insomnia. Even if you're sleeping well, you might be dreaming more than usual. That's a very common thing that we're hearing across the board. You may have new physical symptoms or a recurrence of old physical symptoms. Let's say you used to get a lot of migraines or a lot of tension headaches, and then they went away. And guess what? They came back. Or maybe you tend to get kind of abdominal discomfort when you're stressed, and you used to have it 20 years ago and you kind of forgot about it because it's been gone so long, and guess what? It's coming back. I've noticed some of that in myself. I've certainly seen it in other people too. We're under just so much stress right now that those things are bound to happen. The body will, I always say the body has a tell. Think of like poker players. They say every poker player has a tell. Their eyebrow twitches when they've got a good hand, for example. Well, your body and my body has a tell. It's just natural. It's normal. Now, when they've surveyed Americans during the pandemic, so look at this is back in May, so a couple months ago, fully 50% of people, if you add these three areas, 50% of people will say they have felt depressed in the last week. And that's double the number that we normally have before the pandemic. So it doesn't mean they have major depressive disorder or they need antidepressant medication, but it just means they're distressed. So half of us, are admitting to that. So if you're one of them, guess what? You're probably normal. Now, for folks that are in the trenches, and I'm a psychiatrist, so I'm not right in the front lines, but my friends in internal medicine, critical care, anesthesia, and so forth, they'll tell you lots of worries. Is there enough PPE? In some of your cities, it's a bigger issue than it is in other places. Resources, changing the standards of care. We're delivering care differently than we used to, watching patients suffer and die and so forth. So lots of concerns. Again, I'm going to have to ramp it up here so I can keep moving, but I want to talk about the science of stress. So here's a part of the brain you've never heard of before called the amygdala. It's the fire alarm or the threat assessment part of the brain. And so when we're under stress and we take in a new piece of information, like seeing a saber-toothed tiger, or, new budget crunch problems, or, what have you, the amygdala is going to kick in and pull the fire alarm. And when the amygdala pulls the fire alarm, it's going to turn on the fight or flight system in the brain, which is technically referred to as the sympathetic nervous system. And when you do that, you turn on, again, the fight or flight system. You prepare your body to fight or flee. Your heart rate goes up, your blood pressure goes up, you breathe faster, and so forth. But I'm telling you, the good news is we have this mirror image called the rest and digest system, or the parasympathetic nervous system, and stress management is all about that. How do we turn that system on? And that's called stress reduction. Lots of different ways of doing that, but it can make you feel better and can improve your physical health and even your relationships. Some things we naturally do, we try things, we're pretty resilient. We try stuff to make us feel better. Some things make us feel better in the short run, like using alcohol and drugs or other distracting behavior, like too much internet surfing or online gambling or whatever. I don't recommend that. I don't recommend drinking, a gallon of wine a night. Again, I'm not here to say you got to be a teetotaler, but I do think this is something we need to watch. If you notice you're doing some stuff that maybe you're feeling is not so healthy, keep an eye on that, because it's pretty common right now. What can we do that would be healthier for us? It's all about improving the health of the frontal lobes of the brain, which produce what we call executive functioning. That's part of what the frontal lobes do, is just as you are an executive in your corporation or your healthcare entity, the brain has an executive. It's called the frontal lobes. It produces a series of behaviors we call executive functioning, like planning ahead, having perspective, and so forth. So the way to really get a handle on that, in my opinion, is to focus on the 3 R's. Relationships, staying connected. Obviously right now it's harder because we don't get together literally. Like, again, ideally we would have had this meeting in Chicago at the Fairmont Hotel, and we would be in the same room. You and I would be able to have a cup of coffee or be at a reception later together in the same room, but we can't do that. But in the meanwhile, let's do the best we can and stay in contact with family, friends, and coworkers. We developed a buddy system in my department, for example, where we check in with our work buddy every week to make sure they're doing okay, since a lot of people are working from home. Routines are super important. I'm going to come back to that. And then relaxation, like meditation. I'll talk a little bit about that. So relationships, kind of said that already. Routines, really important. Adequate sleep. I think that's a good place to start, because most Americans, even before the pandemic, not getting enough sleep, and I think it may be worse now. So I think that's a good place to start. Incidentally, I'll give you a little tip. I don't normally like to promote a commercial product, but in this case, I will break my own rule. Have you heard about these corduroy pillows they're selling to help you sleep better? Yeah, pillows with corduroy covering. Yeah, they're really making a lot of headlines. That's a joke. They're making a lot of headlines. Okay, yeah, you might be groaning now, but you'll probably tell it over the dinner table. Okay, exercise. I could go on for an hour about that. I don't have an hour, but just suffice it to say, exercise is not only good for your body, it is incredibly good for your brain. It makes neurons stronger. It reduces anxiety and reduces depressive symptoms and so forth. Getting outdoors is really helpful. If you can exercise outdoors, you get 2 for 1, but even if you don't exercise, healthy diet, super important. Faith and spirituality, whatever that means to you, I think also important. Hygiene, make your bed every day, little things. Routines are really good. Relaxation. Here's a quote from Abraham Lincoln that has a lot to say about gratitude. We can complain because rose bushes have thorns, or rejoice because thorn bushes have roses. I think that's a great quote. The brain is wired in such a way that it is like Velcro for negative events that happen to you, and Teflon like for positive events. Your brain is like that. My brain is like that. So if you find at the end of the day, most things went well, but one thing didn't go well, what are you going to complain to your significant other about? Or what are you going to talk about? You're going to talk about the negative thing, because that's the way our brains work. But if you keep a gratitude journal, that will get better. And that means writing down, not just thinking about, but once or twice a week, writing down 3 things you're grateful for, and try to come up with 3 new things every week, you will over time find yourself happier and more content. Trust me, it works. There are people that have done this over, done lots and lots of research on this. Meditation. I don't have time to practice this with you. This is the 10-minute a day meditation thing I do. Very simple, but takes practice. Takes practice. Basically, you use the word one when you breathe out. So you take a nice breath in, you say the word one inside your head silently. As you exhale, and you do that for about 10 to 20 minutes. I will give you more detailed instructions on this later. I have a document on this we can send around, but I really encourage you to give this a try. I find it incredibly helpful. And I will also tell you that if you do this sort of thing regularly, there is actually some suggestion that it may slow brain aging. There's some neuroscience on this, that meditators, the people with the blue circles, their brain looks, the 50-year-old brain looks very similar to a 20-year-old brain in terms of the thickness of this part, the frontal lobes, compared to people that don't meditate, where it gets thinner with age. Some other practical tips. Right now, there's a lot of information coming at us, so I think shutting off the ping on your phone that pings you every time you get an email. Go check the email at your behest, not when the phone tells you. Stop checking your email at a certain time. Screen time can keep you up at night, so if you're having trouble getting to sleep, reduce your screen time for an hour beforehand. Use trusted sources of information. I like our own University of Nebraska Medical Center website, but your own institution, the CDC, the World Health Organization, and so forth. Lots of misinformation out there. Some other tips on reducing anxiety and worry, just being aware of it, oddly enough, actually makes it better. So if you just kind of admit to yourself, I guess I'm feeling kind of anxious today, and consciously think that lets your frontal lobes take over, and instead of letting the fear center of the brain take over. So the more you can just kind of pay attention to the way you feel and put a name on it, the better you'll feel. Build in some micro practices. Take those deep breaths when you're signing onto your computer in the morning, or when you're using hand sanitizer. That would be an example of a micro practice. There's a bunch of resources I'm just going to skip through because I'm already kind of over time and I want to make sure we have time to talk. The medical humanities, though, just breezing through this, really important. We have a volunteer medical orchestra we started a couple years ago. We have a student singing group called Docapella. We have students that we send off to a local culinary school to learn how to cook, and then how to cook healthy meals for themselves and to teach their future patients. And again, love to talk more about that. If you ever want me to come and talk to your institution about these things, happy to do that when we have more time. But I also like to stop with this slide, that if you have protracted feelings of depression, or you ever feel hopeless, or feel like things are just not under control right now in your life, you're doing destructive behaviors, drinking too much, whatever, not something to be ashamed of. It's something to get professional help for, and there is professional help that really works. So I always like to end that, talking about, if you need it, please get help. So summary here. So it's normal to feel anxious in times of uncertainty, and put a name on it. Say, gosh, I'm feeling anxious. That makes a difference. Stay connected with other people. Remember the 3 R's about relationships, routines, and relaxation. Find the right dose of information, especially about the pandemic. Not too much, not too little. Know that this too shall pass. It's going to be a while, but it will pass. This will not last forever, thankfully. And don't be afraid to ask for professional help. All right, going to end on that slide. Sometimes the grass wins. This is a slide I took when I was out for a bike ride one Sunday. It looked like somebody kind of gave up on that manual reel lawnmower, but sometimes the grass wins the battle. I'm going to stop sharing, and we're going to look at the chat function here, I guess. And got a few minutes here. First of all, thank you. Oh, thank you, Gary, for those kind comments. I'd forgotten that. That was a fun time I had chatting with the good folks at Emory. I thank you for saying that. So open it up. Take whatever you want to chat about, questions you have. Again, I know that was very fast, and tried to cover a little bit of high-level stuff and a little bit of practical stuff. But
Dr. Wayne, that was a great presentation. I've read several first-person accounts about the long hours in the ICUs and just the overwhelming feeling of despair.
Yes. Yeah. So let me comment on that a little bit. So in Omaha, Nebraska, we are not a hotbed, but we certainly have our share of patients. Last I heard, we have about 30 COVID positive patients. Small number compared to bigger cities, I know. But, it's really interesting. A slide I didn't show you, but some of you may have seen along the way. There's a curve. There's a predictable curve of response to a disaster. And you may have noticed this at your institution. I did at ours, that as we could see the thing coming, like in March, we knew it was coming. People sort of banded together and said, okay, by golly, we're going to get together, we're going to come up with a plan, and we're going to fix this, and we're going to repurpose different units and make them COVID units and all that, and we're going to have a volunteer group of nurses and physicians to staff those units. And people just said, by golly, it's kind of like an old-fashioned barn raising here in the Midwest. We're going to raise this barn together. So the morale actually goes up for a while. Then the thing hits, you go through a brief honeymoon period, and then morale goes down because people get tired and reality sets in. We're 4 months into this now, right? And so the reality is hitting, and people are just tired of staffing those shifts, tired of putting the PPE on. It's very cumbersome, and it's very, tired of being afraid they're going to bring something home to their families and so forth. So what we've done for that, and what other institutions have done for that, is lots of informal stuff, like a peer support program that's available 24/7, trying to have break rooms that are staffed with snacks where people can get off a shift, a nurse or a physician can get off a shift and kind of just hang out for a few minutes before they head home and so forth. Lots of informal things like that. But I think peer support's a really important part of that too. A lot more I could say about that, but that's off the top of my head. Those are some helpful things. See, we have another question here too about specific things that our organization can do now with short time and little money. Yeah, that's always the case, right? To offer some relief to our employees. I think, first of all, I think finding a wellness champion at your institution, or champions, there's always somebody, not always, but often somebody like me that maybe knows something about this or likes giving these sorts of talks. Like I say, I'm happy. I can't do everything for everybody, but as my time permits, if you want me to give a longer version of this to folks at your institution, I would be happy to entertain, that possibility. But I think in the meanwhile, finding those champions that kind of know how to keep people connected. I think a lot of this really boils down to social connectedness and, I've seen people in our institution that set up virtual happy hours on Friday and things like that. Those things go a long way, I think. The other thing I do like, though, is coming back to this micro practice thing. It doesn't take much time to do, 4 deep breaths. What if you had sort of a PR campaign at your institution to do that as you're logging on, turning your computer on in the morning, and it takes a few minutes or however long to boot up. I don't know about you, I tend to grumble like, oh, can't you boot up faster? And well, instead of doing that, great time to just take a couple of deep breaths. That's one thing. I would say another campaign we're working on at our place is use your vacation. Our dean of our College of Medicine just put out a really good message the other day saying, a lot of us have to do staycations this year. It's not the same, blah, blah, blah. But even if you take a staycation, take some time off. We don't use our vacation at our institution. Our physicians tend not to, for example. I think that's a pretty good campaign. Take a couple of days off here and there. Those are some simple things, I guess. There's, it's a complex issue, obviously, and I think we're all battling the low, not enough money and not enough time. But I think those are a couple things off the top of my head. I'll give you one more tip while we're waiting for one more question to come in here. I know we're almost, so a little tip for you. So I keep a little orange stress ball that I squeeze sometimes during Zoom meetings, but here's the tip. I also keep oranges. I like oranges, and I guess be careful when you pick, don't pick up when you pick up the right thing, because if you squeeze the orange in the middle of a Zoom meeting, bad things will happen. So that's just another tip there. No extra charge. So that and the corduroy pillows. Remember that corduroy pillow line. You'll like that sooner or later.
There's a question on the screen about, do you have any particular meditation apps that you recommend?
Oh, great. I missed that question. Thank you. So it's in the handout. There's several, and I really like my favorite one of all time comes from UCLA. I don't know if there's anybody from UCLA that's in on this, but it's a really good free app, and it has a bunch of mindfulness things, which mindfulness and meditation, almost the same thing, basically. Lots of really good audio things you can just sort of sit and listen to, can relax your muscles, help you breathe more slowly, and so forth. That's my favorite. So again, look at the slides and you'll see it's called UCLA Mindfulness Awareness Center. Really good, and it's free.
Great. Well, sir, that was very interesting. I think maybe the AAHC could convince you to do a longer webinar and make the webinar available to all of the member institutions.
Great.
And we could show it. We could put it up for the medical students' education, for faculty and staff. And
Great.
you only have to do it once.
There you go. I'd love to do that. That's a great idea. Love to do that. So again, I apologize in advance to those folks on the call here that for talking so fast and breezing through it, but glad you were able to join us here. And I like that idea. So I love that idea.
Great.
Very good.
Thanks again.
Thank you very much. Take care.
So just a reminder, if you do here, I'm back. So just a reminder, if you have questions, use the Q&A function at the bottom of your screen. So our next topic is scenario modeling and long-term planning as a result of COVID-19. And just a few words about planning. In the Defense Department where I work, there's a quote that you hear quite often, and it was first coined by a Prussian general named Moltke in the 19th century. And it translates sort of into no plan survives contact with the enemy. And our current collective enemy, COVID, I think proves the point. In scenario modeling, or in defense speak, what we would call wargaming, is a technique that helps leaders plan for the future. And at its core is the question, what if? So today I'm pleased to introduce our distinguished panel for today's discussion. Dr. Andrea is the Executive Director of Innovation for the Western University of the Health Sciences. And Dr. Case is Senior Vice President for Operations and CFO for the Morehouse School of Medicine. Gentlemen, I turn it over to you.
Thank you, Walter, for the introduction. It is a pleasure to be here. Hello, everyone. I'm going to share my screen. There we go. I hope you are seeing my screen right now. So as Walter said, my name is Miari and I work for Western University of Health Sciences for the Center for Innovation. As a background, Western U is a graduate medical school located in Southern California. So as colleges and universities endeavor to do planning for the start of the 2020-2021 academic year, administrators have engaged into a scenario modeling process and explored educational and curricular possibilities. What I would like to discuss today is a modality instrument that institutions can use to clearly delineate their best fit curriculum delivery method. This tool is called the Digital Learning Modality Quadrant that I will discuss in this presentation. But before exploring the digital learning modality, I would like to present a list of challenges that several health sciences institutions are facing. And I'm pretty sure that you all can identify with these challenges. So without going into the details of what each one of these entails, I would like instead to present different modalities to assist in modeling scenarios to tackle these challenges. So what you're looking at right now is called the Digital Learning Modality Quadrant. So it's divided obviously in 4 parts. So from the top right, moving counterclockwise, the 4 quadrants are the asynchronous face-to-face. The second one is the synchronous face-to-face. The third quadrant is the synchronous virtual. And the 4th quadrant is the asynchronous virtual. So let's go deeper and dive deeper into each one of these quadrants. The face-to-face asynchronous, it does not necessarily require the use of technology as far as the delivery of curriculum is concerned, since the learning activities do not require any technologies. So within that quadrant, we have the hybrid modality. It is essentially a hybrid approach where Some class sessions are being held on premise, and others are designed such that students learn off premise. The permutated modality is where the students are cycled through sequences of learning sessions, and the permutation may involve the use of multiple rooms or location. As far as the alternated modality is concerned, this is where students come to campus in groups or waves and would alternate in attending a session repeated throughout the day. Actually, I know of one institution using the alternated modality that has scheduled alternated sessions from 8 a.m. all the way to 10 p.m. Now the async high flex, and by the way, high flex stands for high flexibility. This modality refers to one that gives students the ability or the flexibility to attend or not on-premise lectures. In this modality, courses are delivered in a classroom setting for on-premise students with the option of being digitally recorded for non-attending students. Now, as far as the second quadrant, which is the face-to-face synchronous, this essentially describes your traditional lecture setting. And this modality can also be used to facilitate group learning. The sync high flex describes a modality where the same professor lectures simultaneously in a live session to a remote audience and an in-classroom audience. Students are given the flexibility to choose to attend a live lecture or log in remotely. I would like to note that actually at Western U, we have been using the Sync High Flex modality for more than 10 years. And we were able to determine that the level of competency is not correlated with on-premise attendance. That was quite an interesting fact that we discovered through a longitudinal study of how our students perform, whether they are using, they are in attendance or remotely attending courses. So this modality can actually accommodate lab sessions through the use of classrooms equipped with streaming capabilities. The third quadrant is the virtual synchronous model. And it goes without saying that this modality is technology dependent because all class sessions essentially are streamed live and scheduled with no on-premise alternative. Faculty members stream live lectures from home or from their on-campus office. And as far as the last quadrant is concerned, this is the virtual asynchronous. This modality refers to self-directed and self-guided learning experiences. It relies solely on technology and digital platforms for the delivery of the curriculum. What we've done in this modality usually is that we are making use of pre-recorded lectures. Actually, and another method that can be, it's an agile implementation of virtual asynchronous learning is through the adoption of adaptive learning. And we are currently using 2 adaptive learning systems. And essentially, this is a cloud-based system that allows our medical students to learn asynchronously, virtually, and the adaptive system would create for them a quote unquote an adapted path or a personalized learning path. And that concludes my presentation. Back to you, Walter.
Thank you, Dr. Andrea. Now we'll move on to any questions for Dr. Andrea now, or do we want to hold them for the end?
Let's hold to the end.
Okay, great. Well, then we'll move on to Dr. Case. John?
Thank you, Walter. I'm going to share my screen here real quick here. Hopefully we're all set. Well, thank you. Happy to be here. Very excited. I'm going to take a little different approach from the scenario modeling and long-term planning than Dr. Andrea, mainly because I want to talk a little bit about it from the finance perspective. And I do want to give you a little bit of history in terms of, in terms of Morehouse School of Medicine. So we're an HBCU medical school. I know we're got a lot of health science organizations here, hospital organizations. We're one of the 4 HBCU medical schools. Obviously, you heard of Howard before earlier today, but we're in that group. We graduate about 125 students a year. We have MD programs, we have a PA program, we have graduate programs in the doctoral sciences and the master's programs too. And so have about $180 million budget and really about 1,100 employees. So we're in Atlanta, and we're we work with Grady as our hospital, teaching hospital. I just really wanted to talk a little bit about scenario modeling in terms of the finances that we've been through. And it says, as a result of COVID-19. When I look at this, all I know is in 2019 or the January, February of 2020, we were really looking at, okay, let's do some 5 years projections. Let's look at all the assumptions we've had for the past 10 years. Let's go through our missions and see where we're going to be on research, our education, what we're going to be doing in terms of the clinic. And we had whatever system we were using, we have our regular budget system, and we do these, and we had people that did them, and it was pretty normal. Well, come March of 2020, I looked at this and I think, okay, once that hit, and all of a sudden we get to the first week, the second week of March, and next thing you know, everybody's shutting down. We had a new train of thought. So scenario modeling was okay. Let's scrap what we have done probably for the past 25, 50 years in terms of modeling, and even in the past year. And we really need to look at this in a different way. We were in a point where we didn't know what was going to happen for the next day, yet alone the next week or month, et cetera. So in terms of our modeling, we had to go right back to what's going to happen. What is our mindset for tomorrow? What is our mindset from finances for the next day? And when I looked at that, what I saw is we really had to just look at our various areas of the school and really look at research. I mean, all of a sudden we were working from home. Who would have thought that, as we stated earlier in the 10 o'clock session, who would have thought we would have been all working from home? And secondly, who knew what we were going to do with our people we had there. So our research volumes, our labs were kind of shut down except doing things from home where they could write papers, et cetera. We didn't know what the federal government was going to do in terms of that funding. So really right when we all changed in that March timeframe, we had to really think quickly as to how we were going to project this out. And so for our scenario modeling, we were really thinking about, we got to get some more guidance, and we did. And scientists were able to use their funds, and it kind of was okay. The one thing about a medical school on the education side in terms of modeling out our finances is that we do usually have a pretty steady volume of students. There's enough students to go around. We obviously probably even have to, get more medical students in. But, I think our educational expenses, we knew we were finishing out a semester. I think like everybody else, that was one that we could in the medical area, in the medical school area, the education area, we could plan pretty well. So the scenarios we had worked out before had really been good. We knew our tuition had probably mostly all come in, and we were pretty set there. We're a private institution, but we do get state funding. And with that, like every other, we heard from Oregon before, they were getting hit pretty hard. We got hit to the tune of saying you're going to be cut about 18% of your state budget. And for us, that was our state budget makes up, our state funding gets about 20% of our total revenue. And that was going to be a pretty big hit. So we had to look at that. We had to immediately look at what are we going to do over the next few months to get by and save some money, because the next year could be a $5 to $7 million in our budget. That's a big amount of money. And then obviously, like everybody else has talked about today, our health clinics took a big hit. Our volumes took a big hit, and we had to adjust for that. So when I look at scenario modeling from the financial standpoint, I think we're all in a day-to-day scenario modeling. We also, with our fiscal year being July 1 to June 30th, we were also in the middle of a budget. And yet really, with the challenges we had, the budget was really put on hold. I mean, we had to deal with how are we going to make it through the March, April, May, June timeframe for those last 4 months of our fiscal year, not knowing when we were going to go back to work, what types of dollars we were going to get. They talked about stimulus. We didn't know if we'd get any of that, et cetera. So we were in the mode of let's put our budget aside and let's start working on a 4-month model. I mean, for us, it was really how do we survive their next 4 months with this new environment that we might have planned for, that we really had a business continuity plan for in terms of how do we convert to, working online, but we really didn't have the financial model there. So, we had to shift the budget process, kind of put that on hold, but also just worry about the next 3 months, which was critical. So scenario modeling for us really went out of the, kind of out of the picture for our finances at that point in time. One of the things that COVID has done to us, and if we heard it before also, even on the earlier sessions, is it's made us all think about our facilities. And we have, and it's kind of in the background here, our brand new facility. It's a 37,000 square foot facility. It was underway. The outside skin was built, and next thing you know, we're building a $14 million build out in the interior. And COVID hits, and yes, construction can continue because it is kind of a mandatory project and it's a mandatory function, and the governor let it go through. But we were right in the middle of financing this, and so one of the challenges for us in terms of scenarios is what are we going to do now? The bank started pulling back. They started just processing the SBA loan programs. They were very busy. They put some of their commercial stuff on hold. So our 2 banks kind of took longer to get us funded. We really had to put some of our own money aside. We deal with the Department of Education, who has an HBCU capital loan program. They were trying to look at us, and they said, we can't do anything for months to get you that money. So, whether it's today or the next 3 to 6 months, when we talk about how we're going to fund future facilities, if we're going to even do them, we saw some people are putting them on hold. We have to think about the capital market is really very slow at this point. They are looking deeper at credit, and it's not as easy as it was, even 6 to 9 months ago. Our biggest thing in this scenarios is what are we going to do about people? And so I talk a little bit about wages. We had to look at, are we going to cut wages quickly? Are we going to look at the benefits? Can we handle keeping those benefits through the year end? Our model that we were working under, work from home, how long is that going to last? How much do we got to do on campus and spend to get people back on campus, which we are back now for half of our workforce, a couple days a week, half of our workforce the other days. Furloughs, et cetera. So we talked about terminating employees too. And really we had to deal with all the expectations from students, patients, employees, all these people asking about their jobs, their wages, et cetera. Parents asking about and students asking about the next year. Our first year started in July 1. So all that scenario modeling from my perspective really kind of just came into a time frame that COVID just put scenario modeling on the map for. It is immediate. It's a 3 to 4 month scenario versus long-term just to get through tomorrow. One thing then I'll just talk a little bit about is long-term planning. From my perspective on the finance side, we really need to understand what the new norm is going to be. I mean, for us, we can see we used to be able to, no problem, do a 5-year financial plan, do some inflationary increases, do some increases in terms of expected research or expected clinical activity that was going to go up. But right now, we got to know what the new norm is. I mean, even now with telemedicine, that's going to be totally different for us. I mean, they may be paying at the same rates as regular visits now, but who knows what they'll do in the future, how that's going to change medicine. If that's more than 50, 60, 70% of our business in the future, how does that look in terms of facilities? So that's one for long-term planning. We really need to wait and see. For us, the business model, how is that going to change also? Reimbursements, I don't know if that's going to change a lot or little or none from our healthcare, our health provider insurance plans. Online graduate instruction, in-service activities for our students, our residents, how's that going to change? So I even look at this from the standpoint is how we are going to be structured from really educating graduate students where people need to be in the lab, the PhDs, et cetera, and the MDs need to be in school to, in the classroom a lot to do teamwork, to do anatomy lab type activities, et cetera. So the business model is going to change. Financing, I stated before that even for the one building, it was a challenge, but I'm not quite sure what the financing market will look like. Are we going to go back to the 2008, 2009, 2010 timeframe when everything gets tight? and there's not much in terms of borrowing. I think for the bigger institutions, that's great. For some small and medium-sized institution, that becomes a challenge. So long-term planning on the financial side with financing is going to be a challenge. And, the most important part we look at really is our people. And that's what kind of guides us. That's what helps us. And, for a lot of us, we're still making decisions on, are we bringing our people back? Are we going to keep all our administration people away till January because they've been doing fine now? Our finance people can work from home, and we don't need to rent that above building we've been leasing, another place. So there's going to be a lot of decisions we need to make. And obviously, even, we talked about it before, we talked about it on the 10 o'clock session, what are we going to do in terms of these buildings that do have administration in there? Do we need them? Do they need to be renovated? Do we need to just have people work from home? There's going to be a lot of people decisions that have to be made. And so our long-term planning for people is still in that rut. So what I wanted to say, just from a finance standpoint, from a planning standpoint, when I look at this, there's a lot of models that we've used over the years to do this in almost every aspect of our business, whether it's mission-based, whether it's administration-based, whether it's facilities-based, or whether it's people-based, is going to change. And for me, it's a day-to-day, week-to-week, month-to-month planning process. Yeah, we got a budget approved for this year, but who knows what could happen if this COVID environment changes over the next 3 to 6 months and gets worse. I mean, we just don't know. So planning is going to be an interesting word over the next year, and then we'll be able to see maybe where we're at in terms of some real long-term planning. So thank you. I'll turn it back over to Walter.
John, thanks for that. It was very, very timely, very interesting. You talk about who might come back and who might not. It's almost as if many of the belief systems that we had about work have fundamentally been, turned on their head. It's like an 18th century model. If you weren't standing by the loom changing spools, you weren't at work. But that's just not the case anymore.
Yeah, it's interesting, and the funny thing is people. I've talked to some leaders and leaders even within the Atlanta area who said, what we did through the work from home time frame is we were more efficient, or we do things when we're in the office that we probably didn't have to do. I mean, some people have said to me, I think we were wasting 25% of our work time by working in the office, because what I've seen over the last 3 months, we've been doing great and we probably need less people, et cetera. So yeah, I totally agree. I think people are going to have a new mindset, and leaders are going to have to think differently about how people work and where they work from.
Not to go dark, but I mean, the people who didn't do their work when they were at work are the people who aren't doing their work when they're at home. But for the most part, I think that and I've seen is that people are actually putting in more time and effort, and we are getting a lot more done. So.
Yeah, I think everybody knows that once that started in March, first of all, we were all trying to plan for the next day in terms of this COVID-19 and what it meant to us, our institutions, the people, the day-to-day management. But yeah, it's all of a sudden you were getting up at 7 a.m. to get on a call, and you weren't getting off till 7, 8 p.m. And people decided that you don't need a lunch anymore either. So you really didn't get lunch. You had to sit in front of the computer and even going to the previous conversation, your back was hurting, your neck was hurting. It was a different March and April, and all of a sudden we were working, harder. A lot of people. I think you're right. A lot of people, maybe not all.
Some of these technologies are actually make it easier to get together. A Zoom meeting is much easier to pull off than an in-person meeting. Trying to get everybody's calendars coordinated and get them in the same place at the same time. So.
Yeah.
I would like to echo the same thoughts that, and again, I'll be very interested to see the studies at the end of this crisis, whenever it ends. But I'm pretty sure that we all agree that productivity actually has increased throughout the whole COVID-19 crisis. It has not hampered, or it has not been detrimental for productivity, for sure.
Yeah. And I would probably agree with that. For the most part, I do believe that there are those who didn't work in the office are working at home. And there are that. I mean, I'm sorry. I've seen leaders do believe that if you're kind of have people that don't work as hard, they're probably that 20-25%. But I totally agree. I think people have worked harder. It's been more difficult. I really say to people, if people walk in here and say they got anything below an 18-year-old that said, I give you a lot of credit because I know I could not work from home during this time frame. Guaranteed, I just couldn't. I just know it. I got through my kids are all 22 and above, and I said, no way. I give you credit. I don't know how you not only were you home with them at home, but you had to teach them. You had to help them with their screen work as far as school. I give those people a lot of credit, and it's a different age, and if they can handle it, great. But I think people were stressed and need that that kind of sessions like what we talked about previously.
Yeah. Dr. Andrea, your statement about the two populations, those who came to class and those who watched the lecture on video and having the comparable results in terms of learning, that's very interesting.
Absolutely. We were actually very surprised because more than 10 years ago, we introduced the concept of using video capture lecture systems. And then we don't take attendance per se, but we let the student decide which modality would be more accepted for any group of the students. So slowly but surely, less and less students actually came to class, but knowing that they could stay home, and this is the HyFlex model, they could stay home, watch the videos, and not only that, but afterwards they could actually repeat, replay the videos and so forth. So we were afraid in the beginning that this would actually adversely impact performance and especially learning. But we've seen over the years that this is absolutely not the case. So again, COVID-19 highlighted this whole concept of HyFlex in academia. And I believe that in a way, we look at this as an opportunity to review, to rethink how we teach and how we learn, because I think there will be many lessons learned at the end of this whole crisis.
Margaret Bell just asked a question, and I actually had it in the tip of my tongue too. She says her students are watching the lectures at 1.5 times speed, and we have many students that do the same thing here. Are you seeing that as well?
Absolutely. And one of the advantages of using the lecture capture system is the fact that you have really good analytics. You can tell when they watched, who watched, how long they watched, which portion of the lecture they are watching the most. For whatever reason, we've identified that, for instance, the Tuesday nights, 1 a.m. There's a high traffic, and we still cannot determine what are the factors that are influencing that viewing pattern. But we are seeing so many good data. We see sections of videos being watched over and over again, and we're finding out that those are actually the difficult concepts. These are the ones that are tougher. And so we then use the data in order to emphasize that it seems like those portions need to maybe supplemental material, learning material, or maybe re-emphasize those because the data is showing that students are particularly interested in those segments.
Can you match the curriculum content to the examination questions in the step 1 and step 2?
Yeah, exactly. Because all of our course contents are tagged. So you have all the course objectives and the keywords attached to every single segments of the lectures. So we can tell which one is which.
That's great. It's fascinating. We heard early on that from the students that they couldn't study at home. Many of them had small children, et cetera, and they were lots of pressure to open up the Learning Resource Center in a structured way with social distancing, et cetera. So we created a reservation system and marked off the tables and the chairs. But it turned out we never had more than 12 people in the building at any one time. So we didn't get close to capacity.
Wow. Did the students have the capability to view the recorded lectures?
Yes.
Yeah, there we go.
But a quiet place to read and think was said to be really important, but then it turned out they didn't show. So.
Oh, I see. We've actually right now we've closed down all the study rooms, and so it will be very interesting as we come back to determine whether First of all, number one, is it safe to reopen them? And number two, if we don't reopen them, what will be the alternative? So those are all among the challenges that we're facing currently.
Well, thank you both for putting the effort in to make these presentations possible. John, it was good to see you.
Good to see you too.
Video.
Yeah.
Get together soon someday.
Yes, you will. Thank you very much for the opportunity.
Thank you.
All right, we'll turn it over to Ms. Bell at this time. Margaret?